Hello, this is the punk rock psychiatrist, and this is your brain on drugs. Today, I'm going to do an episode on how to dose the antidepressants, the most common ones. So we've covered pretty much all of the FDA-approved medications. We do have some more medications to talk about, things like meds that haven't been approved yet that are in the pipeline. I'm going to go over next time. There's some medications about postpartum depression and vasomotor symptoms of menopause, some medications associated with that, and some of those are antidepressants and some aren't, but they treat the same conditions. And then we'll talk about some supplementary kind of things like St. John's wort and complementary treatments like that. So we're not done with the medications, but we're kind of done with the ones that are most commonly prescribed, the FDA approved ones for major depressive disorder. And so to kind of wrap that up, I wanted to go over just how to dose them. I don't think I went into a whole lot of detail when I was discussing these, so I wanted to do them kind of side by side. How do I dose each one of these medications? And I'm not going to go over the MAOI inhibitors and the tricyclics because those aren't used that commonly for depression. You, of course, could look all of these things up in an app like Up to Date, but we're going to go into more details than you're going to find in there and more nuance. And I think for the meds that I'm not discussing, that they have less nuance, and you're going to follow more what the guidelines say. And so let's I've got these in alphabetical order on my slide, so we'll just go through them in alphabetical order. The first one is bupropion. Now, this is a medication. It's dosed between, I say ideally between 150 and 300. Its max dose is 450. And I also have a column, if you have the slides available on my website, punkrockpsychiatrist.com. Max possible dose also 450. Now, some of these meds, the max possible dose can be above the max dose. And you may be wondering, why would I go above the max dose? Isn't it called the max dose for a reason? Well, when these things were, whenever they were approved, maybe the dose wasn't as high as maybe we could go. And there's been further research that's come out since then and case reports that have shown that it's safe and maybe some patients would benefit from it. And so with the antipsychotics, there's a lot of variability here. In fact, the max dose on many of the antipsychotics is way too high. I mean, if you look at the max dose of haloperidol, it's like 100 milligrams a day. We never go anywhere near that. We're maybe 20, right? 10, 20 milligrams. So, and then, things like there are other, Risperidol is another one, a risperidone. 16 milligrams is the max. We never go near 16. Like I would never go above 6, maybe 8 at the most. And then, so in this case, we've got the max doses that are too high. And then there's some of the antipsychotics that the doses, you could go actually higher than what they suggest. So that's why I want to go over this. So bupropion, max dose 450, but like I'm sticking 450 is the max dose that I would use. And that's because of the seizure risk. If you remember, people were getting seizures when the doses were upwards of 600 or more on the immediate release version of bupropion. And when they made the longer acting, they lowered the max dose, the rate of seizures went down pretty much to baseline. Okay, so that's why we really don't want to go above the max suggested dose with bupropion. I would not go above 450. And in fact, I've only even gone to 450 a handful of times. And honestly, I can't think of a single patient that benefited more from 450 than they did from 300. So typically when I dose bupropion, I start people out on 150 for a week. And you could do 3 to 7 days. I usually like to do a week just because it's easier for the patient to remember. And also if you're like giving them a certain amount of medications, it's easier to give them like a week's. I think it's just easier to kind of calculate. I like to see people back on an even number of time, typically about 4 weeks later. And so I give them like a month's worth of medications and then I tell them to go up after a week. I think it keeps things organized. That's just the way I do it. So I'll usually will say 150 for a week and then 300 and then they come back. All right. And then I also tell them, if you went up to 300 and you didn't tolerate it well and you didn't like it, but you didn't have problems or like didn't have that many problems at the 150, you can go ahead and, go back down and stick with that 150. I like to give patients some flexibility when I dose them. I want to get them as better as quickly as possible. And I also want to give them as much control as possible. Um, I think of myself more as like the safety gatekeeper, but this is kind of a psychological thing. And there was a study, I'm going to mention it in a couple episodes from now, where if you give the patient like one choice in the process of like what, some just a choice, what time of day they take it, what med they pick, what dose they pick, if you give them a choice of any kind, it improves the rate of response. Okay. Now, I don't know if you give them two or three choices, if that improves it any more or not. We have this one study showed that you give a patient a choice, some kind of choice at all about the medication, and it improves their outcomes. So I like to, give the person as much autonomy as possible. I prevent them from doing something that's reckless. I feel like that's my job. And I also prevent them from doing something that has no chance of working. Right. So I want to make sure whatever they choose to do, it's likely to have a good outcome and likely not to have a bad outcome. But outside of that, if they want to take something more frequently, they want to split the dose and take it twice a day, you might have a patient that's like, I want to take my Zoloft half a dose twice a day. Well, that's fine with me. I don't know that it's really going to do anything from a chemical standpoint, but if that makes you feel better, you like taking it twice a day, or you maybe you think you tolerate it better if you split it up, go for it. It's not, I mean, that's not going to be in the prescribing guidelines, but I mean, it's fine. Just, I like to give patients the choice. Okay. And so that's why with bupropion, often the choice I give them is, I want to get them up to 300 because I think for the vast majority of patients, 300 is the dose that I've noticed that they get the most benefit. There are patients for which 150 is enough. I've often noticed that those same patients often need 300 sometime down the line, maybe a few months later. I know a lot of people that just do 150 for a month and never and don't increase the dose, and increase it a lot later. I like to get them to the 300 quicker. Most patients can tolerate it, but that's why I give them the ability to. I say, if you didn't, go back to the 150. That's something that I do that I've seen work for my patients. Use it if you want, don't use it if you don't want. But just kind of think, you can embed these kind of flexibilities into the way that you prescribe the medications, and those flexibilities actually can in themselves provide placebo to the patient, them thinking that they have that choice. Oh, if I don't like that dose, I can go back down, or oh, I can go up a little bit more, if I want to. Things like that. Like, what I might do sometimes is like, say they stuck with the 150, right? Say 150, that was what they tolerated. They tried the 300, they didn't like it. They went down to the 150. They come back. I see them again. They're still on 150. They like the 150. And I send them out the door with a 3 month supply and refills because, hey, we've solved your issue. You don't have to come in and keep seeing me for medication management. We found the dose we like, right? What I'll tell them is if you ever need to take 300, or, if you think that, the 150 is not doing it anymore and you need the 300, I will tell them you don't have to see me first. We're already having the discussion today. I've already approved that you can go to 300. So if you want to go up to 300 on your own while you've got like tons of meds I've given you for like refills, go ahead and do that. Try it out. And, if you like it and you're going to run out of meds sooner because now you're taking two 150s and, you're going to run out before, your next refill, you know, you can come make an appointment, check in with me. We can do a call and I'll just give you a new script so that, it'll be an amount that you won't run out of the new dose that you're on. So I'll also do that. Right. So I'll say, you're not on the max dose. You could certainly go higher. If you want to make an appointment first to discuss it, that's perfectly great. If you want to just kind of go up on your own and see how it goes and then let me know, that's great too. So these are kind of things that I like to do to embed that choice in the patient. And these are things that are no risk, right? These are things that I would have done on my own anyway, and I didn't really need to see them to do it. Now, I'm not telling them, go ahead and go up to 600. No, because I would never do that, right? So that's how I dose Wellbutrin. And for, like I said, most patients, I'll do 300, and that's the dose that we go with. But 150 is often good too. Okay. And I mean, another thing, I like to use the XL of bupropion. That's the dose that's the formulation that I like the most because it's dosed once a day. You may have a patient that says, I like taking 2 doses a day. Well, then give them the SR. Give them the SR. And I've had patients say that they prefer the SR over the XL. Sure, okay, go ahead. Let's do the SR for you. And in fact, you've got a patient that can't swallow pills, use the IR. All right, so there's a reason to use all three of the formulations of bupropion. We did talk about some other ones like 450, and there's one that's a different type of salt. I don't see a lot of place for those, but as far as like the IR, SR, XL, you might find utility for patients that like maybe want to take meds 3 times a day or 2 times a day because they're anxious, and just taking a pill has a placebo effect of calming them down. And that's a technique that you can use with Wellbutrin, bupropion, more than any of the other ones because it comes in formulations where you can do that, right? With the other ones, you'd have to say, cut it in half, right? So maybe they think they tolerate it better if they split it, or maybe they think their symptoms are better controlled if they take it more frequently. And so those are some options you have. All right, let's move to the next one, citalopram. Okay, this one is dosed 20 to 40. That's the good range. The max dose is 40, and the max possible dose also 40. And see, this is another one where the max possible dose is the same as the max dose. A lot of the other ones, it's actually higher. But for bupropion, max dose and max possible dose are the same because of the seizure risk. For citalopram, it's because of QTC prolongation. Because of the QTC prolongation, we can't go above 40. And in some, remember when we discussed before, for some patients that are on certain medications that can increase levels or elderly, 20 is our max dose. Okay, but we really, under no circumstance can we go above the 40 max dose because of the concern for QTC prolongation. All right, and with most of my SSRIs, I tend to like to start them on half of the starting dose. So starting dose of citalopram 20, I'll say split your 20 in half. Let's do 10. Do 10 for a week, then do 20. Then I see them back, and then I consider whether I want to increase them to 40 or not. Okay? There are patients out there that you might want to put on 30. Maybe 40 was too much, 20 wasn't enough. Maybe they're nervous to go up to 40, but they still want to increase the dose, so you increase it a little bit less. But generally, I like to double doses when I'm increasing. Okay? So we double the dose of citalopram, we go 10, 20, 40. That's how I like to do it. And the reason why on the SSRIs I like to start at half of the starting dose is to help with those GI adverse effects. The loose stools, the nausea, those type of symptoms, I find that those symptoms happen really readily on the serotonergic medications, and it causes patients to stop medication before we find out if they're going to either tolerate the med or it work. And in order to mediate that, I like to start them at half the starting dose. They're less likely to get adverse side effects, and then they can increase to the regular starting dose after a week. That their body's gotten used to it, they're going to be better able to handle that, and then they're more likely to tolerate it and come back and still be on the medication. That's why I like to do that. And the SSRIs are the ones where that effect is the most common, and so they're the ones that I like to start the really low dose. So with citalopram, it's 10, but we only need a week. We don't need to do a full month. A week is enough to kind of get used to it. Then we go up to the regular starting dose of 20. And then if we need to, go up to 40, and then knowing that 30 is a possibility if we wanted to go there. Okay? And 40, the hard, fast max dose on citalopram. Next one is desvenlafaxine. If you read, this is an SNRI. If you read the prescribing guidelines, it says the max dose is 100, but and this is interesting. Some of these don't have hard and fast doses. They'll say, oh, max dose is 100, but can be dosed up to 400. But then it also says that there's no evidence that doses more than 50 are useful. All right. So, like, what do you do with this for the desvenlafaxine? Well, I mean, it means that you give them 50. Maybe you cut that in half, 25, then go up to 50, and you kind of stick with 50, kind of thinking that that's the max that's going to be beneficial, but knowing that you can go higher. Okay. Just because the evidence suggests that on average patients don't do better at higher doses doesn't mean that there aren't going to be a handful of patients where that can be done. And so 100 being the max dose, you could easily and safely go up to 100 if you wanted to. Now, what's nice is we do have this buffer to go up to 400, even though that's above the max dose. It's something that's been proven to be safe. So if you've got patients that you think might benefit from a higher dose, we can go up as high as 400. And so that's nice to have that flexibility. And what patients might you want to go higher than the max dose? Um, this is kind of how I gauge how I increase meds and deal with max doses. First, if somebody is tolerating the med completely fine and they've had no effect, this is a patient you can go up. I see this all the time where patients are not even increased to the max allowable dose. Not even We're not even talking about max possible dose. Max possible dose is like a theoretical kind of thing that, we've had case reports and things like that that suggest this is safe. But the max dose being like what the drug manufacturer got the drug approved to be labeled as the max dose. I see patients that don't even make it to that max dose, and they come in and they're on a lower dose, and I'm like, and they're like, oh, it doesn't do anything. I don't feel bad. I don't feel good. It just does nothing. And they've been on it for months. And I'm like, why haven't it? Why? Or they've had another med added to it before this med is maxed out. This is another principle. Max out the benefit of one med before you add other meds. Okay. So don't go adding Wellbutrin to your desvenlafaxine if you haven't taken desvenlafaxine to the max dose of 100. There's no point in it yet. We should at least get them to that max dose. And here's the other thing. If they're on the max dose and they've had no benefit and no side effects, and this is a med that I can go above the max dose on, I'm going to go above the max dose. And with desvenlafaxine, we can do that. We can go as high as 400. So if you're on the max dose of a med, if you're on the max dose of citalopram 40 and you're tolerating it fine and not having any effect, I'm not going up, right? Because of the QTC issue. Hard fast 40 milligrams. In that case, I'm going to stop citalopram and put them on something else. And this is another issue I see. I'll see providers that have, the patient is not benefited, tolerated fine, max dose of a med, we're getting nothing out of it, and they add something to it. And it's like, no. Why are we keeping a med that's doing nothing? Let's get rid of it. Let's get rid of that one and replace it with something else. Let's not add more on top of it. This is a useless med for us. This doesn't work for this patient. Okay. So I'm going to max out a medication as high as I can, and either until they don't tolerate it or they get benefit from it, and max benefit. Say you're on the max dose and you're noticing a little bit of difference. Oh, okay, I'm on 100 of desvenlafaxine and I feel a little bit better, but I'm having no issues with it. This is a patient that I'm going to go above the max dose on. Hey, maybe we haven't reached the max benefit on this patient. Let's go a little bit higher. This is a med we can go higher. Let's go higher. All right. They're tolerating it fine. They're not having any adverse effects. And so maybe they'll have adverse effects at a higher dose, but they haven't had any yet, and they're having a little bit of benefit. Rather than add something on top of this that has a different mechanism of action, let's keep pumping this med up and see if we can actually get more benefit from it, okay, before we start going polypharmacy on the patient. All right, so that's the beauty of, one, having a max dose that we can go to easily, and then having some of these meds where we can go to an even higher dose. All right, desvenlafaxine being one of them. Next, duloxetine. This is one, it comes in, I think, 20s, 30s, and 60s, I believe, are the pill sizes. The general, and they say that you can actually start it as high as 60. And 60 tends to be the ideal dose for most patients. So, the ideal range is somewhere in the range of 40 to 60. And you can start them, I think it says start 30 to 60, but I mean, they make it 20, so you could start people with 20 as well. This is a pill that you can't split. Um, and so because you can't split it, you have to, dose it in amounts that you can add up to with the pills that you have. With citalopram, I can say cut that 20 in half and take 10. We can't cut duloxetine in half. We'd have to give them a different size pill. So 40 to 60 is a general range we want to have them for. The max dose is 120, and the max possible dose is 120. Now, I don't know that doses higher than 120 are unsafe, but there hasn't been a lot of research on doing that. And in fact, just like with desvenlafaxine, where it said doses higher than 50 really haven't been shown to have any benefit, with duloxetine, doses higher than 60 really hasn't been shown to have any benefit, though the max dose is still 120. So really no reason to go above 120 on duloxetine. And for most patients, I have them on 60. I have a few patients I've given 90 and 122. Maybe they did a little bit better, maybe a few, but most, you're maxing out your benefit at 60. So you can go ahead and go above that for some patients. You can go as high as 120, see what happens. But for most patients, we're looking at 60. And duloxetine, I've found that I can actually start with 60. With I don't, I, with some of the other ones, I like to start at half the starting dose. With duloxetine, I kind of gauge it. If this is a patient that says they're really nervous about meds, they've had a lot of side effects with a lot of other medications, I'm going to start them at probably 30. If they're super nervous, I may even start them at 20. If there's someone that I don't really have this concern for, um, I might just throw them straight on the 60. It's some the prescribing guidelines allow for that, and I've done that several times, and I have not had problems with doing that. And I like that because then I get them to the 60 faster, and I don't have to go through the doses that are, maybe not that likely to work. Because I mean, the dosing range here, we're looking at 40 to 60. So if I start them on 30, they're probably not going to get much better with just 30. That's just kind of a get used to it dose. If we go straight to 60, we might get them better faster. And like I said, I haven't noticed the tolerance issues with duloxetine that I've noticed with the SSRIs. That's not to say that you're not going to have it, but I'd say it's less often. So that's how I dose duloxetine. And if you go to 120, you could dose it twice a day if you wanted to. I've seen that. Someone maybe does a 30 and a 60 or a 60 and a 60 spaced out. I think they even say that in the prescribing guidelines to split it if you go above 60. I've split it and I've had it all at once. Okay. Now, in many cases, if the patient tolerates taking it all at once, it's typically easier for them to remember to take all their medications if it's all at one time. If they're having some tolerance issues, you could, of course, split the dose. Maybe they're having some GI upset, but if we split the dose, they don't. Well, then do that. Kind of look and see how the patient responds. You can split anything. I mean, and by split, I mean if you can split a pill if it's splittable, and if it's something like duloxetine, you can give them just two separate pills that they take one twice a day. Okay, so you're splitting the dose with two separate pills. Next, escitalopram. This is one that I prescribe a lot. The ideal range is 10 to 20. Max dose is 20, and we can go as high as 40. All right, and I have. Um, this is one where I like to split the dose in the beginning. So starting dose is typically 10, but I'll do half that, 5 for a week, then 10. I see them back. If we want to go up further, we can go to 20. And like I said, I use the same principle with these. If you're tolerating it and you're not benefiting from it, I will keep increasing the dose. If you've got someone who maybe they've been on 20 for a while, it worked for them for a long time, and now they're saying, I'm not, maybe I'm getting used to the dose, maybe I'm getting tolerant, maybe, some other things are happening, and it's just not working as well as it used to. I think a lot of people's impulse is, well, let's switch it or let's add something. Well, my impulse in some cases might be, well, why don't we increase the dose further? We may be at the max dose, but we can go as high as 40. So why don't we try 30? See how you do with that. You're tolerating it fine. You're not having any issues. A lot of patients are having issues. And in that case, we can't go up any farther. But if you've got a patient that's not having any issues, they're not having GI upset, they're not having bothersome sexual side effects, they're not having headaches or whatever it may be, go ahead and go above, on citalopram. We can go 30, 40 with that, with this one. All right. Um, so, but this is, again, one that we don't have a lot of evidence that doses higher than 10 are effective, right? So the max dose is 20, but 10 for most people is probably enough. I mean, I've actually had some patients on 5 and it was enough. All right. I've mentioned this, and I'm, like I said, I'm going to have a episode that covers all about like basically like how to use therapy as you prescribe to max out what you're doing with the meds, because the placebo effects are so big. If the patient, just the act of taking a med is giving them the effect we want, we don't need to give them higher doses, right? Because just higher doses just increases your likelihood of getting side effects. If you're on the lowest possible dose and you're a lot better because we're getting this massive placebo effect, awesome. Because at those low doses, you're actually not that likely to get the side effects. We don't even have to worry about the side effects. And you're getting the benefit because it's mostly placebo and that's all you needed. But if you hadn't seen me and you hadn't taken a pill and you weren't putting a pill in your mouth every day, you wouldn't be getting that effect. But we don't need to put that much in there to get that effect. Awesome. Always best to try and keep patients on the lowest effective dose. But if it's not, you know, taking more pills and larger pills and just mentally knowing that you're taking higher milligrams, that has placebo effect as well. And of course, all these meds also do have effect as a med, right? And so taking a higher dose is going to do more serotonin reuptake inhibition, which could lead to more effect. All right. So we've got two effects. We've got both the placebo is ramped up with higher doses, and also the effect of the chemical is ramped up with higher doses in the pharmacology of how it works. All right. But, you know, I like to try and keep people on the lowest possible dose. And like I said, if it's not doing anything and they don't feel good or bad, then go ahead and crank it up as high as my chart says you can. All right. Next, fluoxetine. So this is our normal range that we want to have patients in is kind of in the 20 to 40 milligram range. I start people 20 is the starting dose. I start them with 10 for a week, go to 20. If I can keep them at 20, I'll keep them at 20. If we need a little bit more, I'm happy to go to 40. The max dose is actually 80. All right, so I've had patients on 80. Going above 40 is often not that beneficial, but with certain patients it might be. Go to, and this is a med, remember, that doesn't have the linear kinetics. And so remember, paroxetine and fluoxetine, because they inhibit their own metabolism, when you double the dose, you're quadrupling the dose. And so we increase these slower, right? Remember how I said with citalopram or escitalopram, we're doubling the dose 10, 20, 40, 5, 10, 20, 40, something like that. With fluoxetine, I'm going to go 10, 20, 40, 60, 80. So I'm going to have that 60 dose in there because if I go straight from 40 to 80, I'm actually maybe quadrupling the dose because it's inhibiting its own metabolism. So it increases its own levels. Paroxetine is the same. We'll talk about that in a second. So this is one where I do want to go through that 60 milligram dose. With some other ones, like with citalopram, do you want to go 20, 30, 40? You could, but you feel free to go 20, 40. Maybe you could back down to 30 if you needed to, but for most people, you're not going to need to worry about that because if we're just increasing the dose by 50%, not that likely to get that much effect. Doubling the dose tends to do more. But with fluoxetine, we go 40 to 60. That's kind of doubling the dose because of the kinetics of the medication. All right. So, and then we've got 80 as the max recommended dose, but we can go as high as 120. Now, another thing I want to say about these max possible doses that are above the max doses is that for depression, this is typically not warranted. All right. Remember, I have 3 columns. We're talking about the optimal dose for depression, which is kind of in the lower range. For fluoxetine, we're on right now 20 to 40. The max dose 80. For most people, 20 to 40 is fine. 80 is the max dose. 120 is kind of the the max possible dose. For depression, we're not going to tend to need to go near this max possible dose. With anxiety, it might be a little bit more needed. And with OCD, that's the disorder that I'm going to be the most thinking about going to these max possible doses, because OCD tends to need higher doses. Depression tends to need lower, maybe anxiety's next, and then OCD. So I think lower doses for depression in general, and I think the highest doses for OCD. So could you go to these max possible doses for depression? Certainly. But with OCD, you're going to be looking at doing that more often. And we're going to talk about OCD in another lecture series, and I'll bring this up again. I'll go into more detail. But when I'm thinking about these max possible doses, these are things that if you've got a really stubborn depression, or maybe someone's been on a med for a long time and they become tolerant, you could consider going up a little bit higher. They've got anxiety on top of it. They've got OCD. And then another thing might be that just the way that their particular metabolism works. And I'm going to mention that after we go through these meds. Some people metabolize faster and some slower. And so if you're a fast metabolizer, you may need these higher doses. Okay. So next med on the list is fluvoxamine. Optimal dose for depression, 100 to 150. The max approved dose is 300, and that's for OCD. This is a med that's only approved for OCD. So it's actually not approved for depression at all. That max dose is for OCD, and the max possible dose I also have as 300. Next, mirtazapine. And fluvoxamine is a med that I'm not going to prescribe that often, and I'm going to go on my same principle. I'd probably start with 50 on this one. So mirtazapine, optimal range is 15 to 30. I often start 7.5, especially if I'm only looking at dealing with insomnia. I'll tell them take half the 15, 7.5 to one of the 15s. And you could do the same thing if you were going to do it for depression. You could start with 7.5, go up to 15, 30, max dose is 45, a max possible dose of 90. However, 15 to 30 is our typical range that we're going to use for depression. Paroxetine. This is a med that we start with 10, so I might start with 5. The optimal dose is 20 to 30. This is the other med that it inhibits its own metabolism. So I'm going to go, 10, 20, 30, 40, 60. All right. So I don't want to double the dose here because of the metabolism of this med, just like fluoxetine. So we'll do that 10, 20, 30, 40, 60. The max approved dose is actually 50. So even though I said I go from 40 to 60, that's typically what I would do rather than going to 50. But the max possible dose is 75. All right. And I've gone as high as that for OCD in this med as well. Sertraline. Sertraline's got a lot of flexibility. Starting dose is 50. Optimal dosing range is 50 to 100 for depression. I will typically start patients on 25 for a week and then go to 50. The max approved dose is 200, but you can go as high as 400, and I've given people typically from 200. I'm not going to go straight to 400 since we're like going above the max dose. I'd probably go to 300, and then if I needed to, go to 400. And that's mostly, like I said, in patients with OCD. But we can go as high as 400, even though the max dose is 200. Next, we have trazodone. I'm usually using this for sleep, and I'm giving people, typically I'll give them a 50, and I'll tell them start with 50. If it's too strong, cut it in half. Not strong enough, double it, take 100. If that was too strong, go to 1.5, 75. And so I give the patient, and because we're treating insomnia a lot of the time with trazodone, whereas the antidepressants, they take 4 to 6 weeks before we see a difference. I don't want to be really toying around with the dose too much until I've had enough time to see if it's going to work, see if they're going to get used to the side effects. Maybe if their side effects were really bad, I would consider lowering it, but still giving it that 4 to 6 weeks at that lower dose before changing it. But with trazodone, when we're treating insomnia, and I'm typically, even if I'm using trazodone for depression, it's going to be in a patient who's having insomnia. And so we can toy with the dose a lot more because insomnia is going to respond to the med like the day you change it. You don't have to get used to the dose. For depression, there's a lot of we talked about the brain changes its architecture and it takes a long time before we see the benefit from that. But insomnia, if you don't like I might say take it a few days, but even one day, if it's like not enough, you could go up in dose, right? That's just something that responds faster. You're going to respond faster insomnia. So with trazodone, I'm going to give them a lot more flexibility in how they dose it and how quickly they change it. I will often say, you could take between 25 and 100. All right. Start with 50 and just kind of go in 25 milligram increments as you see fit between 25 and 100. And then come back and we'll see what you're on. I've even with some patients said that they could go as high as 150 before they come back. Especially patients that like they've had a lot of problems sleeping and like a lot of stuff's not working. I'm thinking they might even need more than 100. Probably not, but maybe. And I want them to get that fixed as soon as possible. So I'll tell them, hey, you can go ahead and go as high as 150 before you see me again. And remember, our optimal dose for depression is 150 to 300. So, getting them to that 150 dose may be helping us with depression as well. And, that's going to be really beneficial for us. All right. So, if they're the kind of patient that you think, might need a little bit higher dose, you're of course not going to say take that dose right away, but you give them the flexibility of like try 50, try 100, try 150, then come back. Okay. Most people I say to take between 25 and 100, but like I said, some I will give license to go up to 150. It's completely safe because the max dose is 600. And this is a medication, remember, that we dose twice a day, so it's like 300 twice a day. But also remember when we talked about trazodone, you can take all the dose at once and it'll be more likely to be tolerated and help with depression and insomnia at the same time. All right. And our max possible dose of trazodone is also 600. I can't imagine ever needing to go above 600 with trazodone. I've had patients on some patients with pretty stubborn insomnia I've had on 300. I think I even had someone on 400. But I've never gone to 600. We go through these doses. Bupropion, have I gone to 450? Yes. Citalopram, I've gone to 440. Of course, desvenlafaxine, I don't use very often, if at all. I can't even remember using it. So have I gone to 100 or 400? Probably not. Duloxetine, I have gone to 120. Escitalopram, I have gone up to 40. Fluoxetine, I've definitely gone to 80. I don't know if I've ever gone to 120. Fluvoxamine, I rarely, if ever, use, so I don't think I've ever had anyone on 300. Mirtazapine, I've gone to 45. I don't think I've ever gone to 90. I've heard of it. Um, Paroxetine, I have gone to 75. Sertraline, I think I've gone to 400. I've definitely gone to 300. And trazodone, I think 400 was the highest dose I went to. So I've gone to the max possible dose with most of these medications. But trazodone, yeah, 600 is plenty high. I can't imagine needing more, and we're not going to go higher than that. And then lastly is venlafaxine. 75 to 150 is the optimal dose for depression. I will typically start people at the 37.5 dose. This is a IR and XR versions, but I typically only use the XR, so we can dose once a day in the morning. I go up real slow and I go down real slow because, and I don't like it, right? As you know, this is one of my least favorite medications. The max approved dose for depression is actually 225 for the XR, but 300 for the IR. I'm not exactly sure. Does that mean that 225 of XR is equivalent to 300 of IR? Or, I don't know how we arrived at these two values. I will frequently go to 300 with the XR, but our max possible dose is actually 600. And remember, with venlafaxine, up until 150, you're mostly just getting an SRI. Then beyond that, you're getting the NRI. So, like, we're not even really getting the SNRI quality until we go above 150, which is why I might even using this med if it's just going to be an SSRI and it's like poorly tolerated. And that's like the normal dosing range for depression is 75 to 150 anyway. But you know, I'll take them up. Then beyond 150, we're getting the NRI in there, and then actually beyond 300, we're getting DRI, dopamine reuptake inhibition. And so there may be some utility to going to this max possible dose of 600 because at the up to the 300 milligram dose, we're not getting that dopamine reuptake yet. And so the great thing about venlafaxine could be that you could get SNDRI out of it if you go above the max dose. All right. So I hope that explains things pretty clearly and that you're kind of, having a better grasp of how to dose these meds. I also want to note that 5% of patients fall outside the bell curve and may require higher or lower doses. All right. So a very small number of patients, and I've seen these, like I said, I had a patient on 5 milligrams of escitalopram, any higher, and she didn't tolerate it. All right. And then, so not only do we have these max possible doses being higher than maximums, because you have this few percent of patients that just need these a lot higher doses because of various reasons. You have the opposite too. You've got patients that, like, maybe you put them on the starting dose of escitalopram of 10 and they didn't tolerate it well at all. And then we never had a chance to find out if it was going to work. And if I see this in a patient, I'm going to say, well, why don't we try 5, right? Because if you're having that strong of a response at, the regular starting dose, well, maybe you're going to benefit from a lower dose and not get the side effects, right? So that's another thing to consider. I think some people might start people on the starting dose and the patient doesn't like it, and so they just switch to something else. Well, if you switch to something else, you may end up with the same problem. And you may notice a pattern that they've taken 3 meds and not tolerated any of them. And then what are you doing? You're giving up, you're using other meds, you're trying different things, when really what you could do is give them what would be considered a subtherapeutic dose, but it's therapeutic for this particular patient, right? So keep that in mind that, while it's okay with many of these meds to go above the max dose, it's also always okay. We can always go below the minimum dose, below the starting dose. And you may think, well, that's useless, but this patient may be different. Okay. So, and why might that be? I wanted to talk about this when I talked about psychogenomics a little bit later. I was going to bring this topic up, but I think just kind of to explain, why some patients might need higher or lower doses. One reason is how they metabolize, right? So most of our antidepressants are metabolized by 2D6 and 2C19, right? And you've got what's considered a poor, an intermediate, and rapid metabolizer phenotypes. So this is, you have this gene that produces this enzyme, 2D6, in your liver, and some people's 2D6, there's different morphologies to them, right? They don't look exactly the same from one person to the next. Some people's 2D6 enzyme functions really, really well, too well. And some people's doesn't function well at all. And then some works the way that we expect it to work. All right. And a lot of this is dependent on race. So, for example, when we look at the Asian population with 2C19, 18 to 23% are poor metabolizers. Japanese around 20.3%, Chinese 13.6%, and Korean 13.7%. But for white population, 2 to 5% are poor metabolizers. With the black population, 1.2 to 5.3%. So this was my patient that I gave 5 milligrams of escitalopram to. She was Japanese. And so I kind of thought, 20% of Japanese are poor metabolizers of 2C19. Escitalopram is broken down by 2C19. Maybe she's breaking this down really poorly. She's one of these really poor metabolizers, and we'll give her a lower dose. And it seemed to work. And then on the other hand, you have and that's a big one I think about. I think about Asians and poor metabolizers of 2C19, which is citalopram and escitalopram. And then with 2D6, which is what most of the other medications are metabolized by, I think of ultra rapid metabolizers. Okay, so Asians 0.9% to 21% could be ultra rapid. And then the white population, 7 to 10% are poor metabolizers. So when I've got a white patient, a lot of them are going to need extra low doses of the 2d6 meds, and that's most of our, that's most of the medications are escitalopram, citalopram are 2c19, bupropion's 2d6, but most of those other ones are sorry, 2c9 is 2c9, but most of the other ones are 2d6. Okay, and so you might need lower doses, more likely to need lower doses with the white population. Now, does that mean that that doesn't apply to other ones? No, 7 to 10% of white, 1.9 to 7.3% of black, and 1 to 8% of Asian. So just because you're white doesn't mean only whites could be poor metabolizers. No, they're just like the most likely to be. Okay. But anyone could be a poor metabolizer. It's just like if I have a white patient, I may be thinking about that a little bit more. Okay. And then the ultra rapid metabolizer, Asians might be more likely to be ultra rapid metabolizers of 2d6. And so this is where, if you're a poor metabolizer, you're not metabolizing the drug, so the levels get higher. And so a small dose will feel like more. If you're an ultra rapid metabolizer, that means you metabolize the drug too fast. And so even taking the max dose, your body could be getting rid of it so quick that you can't even use it. One way around this, if this is the case, is you could use a med that's not in that category, right? So if you're having problems with 2d6, whether you need your ultra rapid or poor, maybe we give you the 2c19 drug. And so now we don't deal with this issue anymore. Okay. Or we just give you a lot higher doses or a lot lower doses because maybe the 2c19 drug didn't work. Maybe you needed the 2d6 drug. So those are some ways to get around it. You could either, that's why switching meds might help. And when you're switching meds, you might be thinking, oh, I want to use a med that's a different, metabolized by a different enzyme because this patient might be in this category. And this is one reason why people order those psychogenomic tests. And I think they're kind of garbage. I think the only useful piece of information in there is whether they're a poor or ultra rapid metabolizer. And I don't think I need the test in order to solve the problem, right? I can think about how the patient's reacting. I can give them a med that's metabolized by a different enzyme, and see how they react to that. Or I can increase or lower the dose and see how they react to that. And I didn't really need that information. But if you have that information, if the patient comes to you with it and they show it to you and say, look, here's this is here, well, evaluate the meds they're on and see if anything might be affected. And if you need to make a change based on that, go ahead and do it. But like I said, I want to go into more detail about that because there's a lot more psychogenomic testing that goes on. This is just the one that I feel like is the most practical to actually help you. These ones that spit out things and say, "Oh, you should take this med," that's crap. That's just basically the test is just picking a med that's not one of the ones that is affected by your enzymes. It's like not like, oh, you have the chemistry that like reacts to this particular drug. That's kind of what they make it sound like. Oh, this is like what your brain is looking for. No, it's mainly just looking at these enzymes. And then the other stuff in there is mostly garbage and unproven stuff. Okay. So this is why we might need to go outside those prescribing margins. There are other reasons, but just keep in mind that you can always go too low and in some cases can go too high. Okay. And then just one final note on dosing. I want to touch on hepatic and renal dosing. I'm not going to spend a ton of time on this. It is an easy thing to look up. If you look up dosing, there's hepatic and renal dosing for every medication, but I've kind of consolidated that and I'm just going to kind of list off the ones that you need to be concerned about. All right. So, and this is cases where so hepatic dosing, first of all, what is it? This means that, maybe you've got some liver impairment and some drugs may be affected by having that impairment. Maybe you need to take a lower dose because, the, the liver is really important in processing this drug. And if it's not functioning as well, then you need to take a lower dose. On the flip side, there's medications that aren't processed by the liver, so this would not matter. And we would not need to worry about hepatic dosing for something like desvenlafaxine, which is not processed by the liver. So we wouldn't even need to worry about it, right? And then with renal dosing, same thing. Someone who's got impaired renal functioning, do we need to lower the dose? Some meds aren't really affected by the kidneys, and so those we wouldn't really worry about. Some are very affected by the kidneys, and we really need to worry about it. Okay, So that's basically, if they don't have hepatic or renal impairment, then we don't need to worry about hepatic or renal dosing at all right. So looking at hepatic dosing, the medications that, if they're on these meds, we don't need, if and they could have cirrhosis, like they could have massive hepatic impairment, and we're just really not concerned. There's no dose adjustments at all. Desvenlafaxine, right? It's a metabolite. Milnacipran and levomilnacipran, and then we've got vilazodone and vortioxetine. These are meds that, I mean, desvenlafaxine would be the one that I would really think about because it's not metabolized at all by the liver. If someone was completely liver impaired, I don't think I would necessarily want to give them milnacipran, levomilnacipran, vilazodone, or vortioxetine because those are processed by the liver. But if you look at the prescribing guidelines, it says no adjustment necessary. Um, but like I said, if they had severe impairment, I would probably be looking at desvenlafaxine because it's not going to be involved at all. So those are the ones that are listed as no adjustment necessary. And then there's two drugs that are actually contraindicated with any impairment. So any hepatic impairment whatsoever, even mild hepatic impairment, don't use duloxetine, the SNRI, and don't use isocarbazid. That's an MAOI that you're probably not using anyway, but those are the two that, like, any impairment at all, it's like contraindicated. Okay. And then what meds is there a dose adjustment recommended? All right. So this is, you've got some hepatic impairment. Is it mild? Is it moderate? Is it severe? Um, Usually they'll have it ranked like that, and it'll say, if it's mild, lower it by this much or use this dose. If it's moderate, lower it even more. If it's severe, lower it even more or don't take it. Okay. So you have to look them up individually. It will kind of, what impairment they have will kind of dictate what dose we can use. So which meds do we need to adjust? Remember, so the first class I listed, we don't need to worry about adjusting at all. The next ones, if they have any impairment, we just don't use them at all. But this is a class of meds that if they have impairment, we can use, but we need to lower the dose. All SSRIs, venlafaxine, bupropion, gepirone ER, doxepin, selegiline, phenelzine. Okay, you're not going to be able to remember that, but it's most. And then everything that I haven't listed, there's no recommendations made, and it says have caution. Okay, so it's no recommendations but caution. So I would be careful with those. I think the big things to know is that desvenlafaxine is our safest med that we've listed for hepatic impairment, and duloxetine and isocarbazid, but mostly we're thinking about duloxetine, is the most risky. Those are if you remember anything from hepatic dosing it, and antidepressants, know that desvenlafaxine is super safe because it's not metabolized by the liver, and duloxetine is contraindicated. Those are the two most important things that you should remember. All right, and then let's talk about renal dosing. Most of our meds don't require any kind of adjustments with renal impairment. Um, all SNRIs do, gepirone ER does, and paroxetine does. Okay, so not that many. Those are the ones that you need to remember. Um, so if you think about duloxetine, it's contraindicated with hepatic, and it also requires renal dosing. So it's one we worry about for both. Gepirone ER, it was one that needed adjustments with hepatic, and it needed renal adjustment. So that's another one that we need to think about for both. Venlafaxine, another one we need to think about for both. And then paroxetine is another one you think about for both, right? So, and then desvenlafaxine, whereas we don't worry about it at all for hepatic dosing because it's meds that tend to be metabolites and are not processed and metabolized by the liver. They tend to be the most affecting the kidneys, right? So desvenlafaxine even is a med we totally don't worry about for the liver, but then we really worry about for the kidneys. So it's another one I think about is gabapentin. Gabapentin we don't think about for hepatic dosing at all, but then I really think about how it affects renally. That's just a general kind of principle. Um, Meds that don't need to be processed by the liver are more highly affecting the kidney, because the liver is not changing them into something that's safer. The kidney is doing most of the work here. And so we need to worry about more about the kidney with drugs that we don't worry about the liver. And that's kind of the way I think about it. Okay. So renal dosing, all SNRIs, gepirone ER, paroxetine. So, just something, if anyone, if a patient has hepatic or renal impairment, you should be looking their meds up. You should just be looking them up. This is kind of an advisory to kind of put that thoughts in your mind. Always good to remember duloxetine's contraindicated, and always good to know that meds that are metabolites like desvenlafaxine are ones we don't need to worry about the liver. The rest of the stuff I think is probably too hard for you to memorize, but just it's just good to know that most of our meds you do need to have some concern about, and you're probably not going to remember which ones, and so you should look them up. All right. So that's going to wrap up the episode on dosing. I hope that was informative, and I gave you details that you're not going to find in the prescribing guidelines, details that you weren't going to find if you used UpToDate or whatever, Hippocrates or whatever it is that you like to use. That I've given you like details on like how precisely I prescribe these meds. And what I'm trying to do here, I'm trying to avoid adverse effects, trying to improve tolerability, and I'm trying to maximize effectiveness. If they're not getting the effect, we can go a little bit higher. That's what we're always trying to do: mediate the downsides and enhance the upsides. And each med I kind of toy with in a slightly different way, based on how it works, maybe what its dangers are. I don't want to go too high with ones that are more dangerous, like bupropion and citalopram. And that this is conceptually kind of how like I process through this, and hopefully that all makes sense. And you're like, okay, that's why I would want to kind of go slower with this one, or maybe I wouldn't want to go above the max dose with those, but these like we have evidence that this could be okay, but I'd only do it in these certain situations, because I want you to feel comfortable with this. Okay. I think a lot of people, they're uncomfortable going to the max dose and maybe uncomfortable going above the max dose. And then patients don't necessarily get better. Know when you can go above, know when you can go to, know when you should back off, know when you should go slower, right? You should not be afraid when you're prescribing. If you're afraid, that means that you don't have all the information. And if you don't have all the information, you're more likely to make a medical error. All right. Because I have this information, I then feel comfortable doing things that are maybe outside of the guidelines because I know the data behind it. I'm like, okay, well, I know this one's safe and this is why. And these are the things that I would look out for to make sure, we weren't having a problem with this. Maybe I need to get an EKG if I'm going to go above the max dose because they've got some sort of cardiac condition and there's like a mild risk of QTC prolongation. If you have all that information and like all the safety data, like mainly what I want to teach you is safety data, because that's what helps you maximize the benefit from the patient. Because if you're scared, you're like, oh, I don't know what's going to happen if I do this. Well, you need to know what's going to happen so that you can do it when it's indicated. All right. Especially if you're like an NP or a PA or family medicine or like lower experienced and you haven't had this time, you need to be familiar with all this safety data, because that's what's going to allow you to freely prescribe these medications to the max benefit of them and help the most patients and feel confident and safe doing so. All right. So I hope that this was like as great as I love to talk about dosing. It's, I think, an interesting concept, and I think it's something where a lot of people, they just follow the guidelines. They don't go outside of the guidelines. It's like, well, I have to start at this dose. I can't go above this dose. This is the pace I have to go at. And there's flexibility there. Some cases you need to do that, and in some cases you don't. And you need to know which ones they are, because you can personalize your treatment. So I want to thank you so much for tuning in today. Please rate the show, and tell people if you think it's great. And I'm excited. We're going to talk about like antidepressants on the frontier, stuff that's coming down the pike. And that'll be next time. So thank you for joining me, and I'll see you next time. Whoops, IOD. Shortness of breath.
call ambulance. Tell my Wi-Fi. Error in judge. Man cut my life. No second chance. No guiding light. I never meant to cause